Hello, my name is Arati Gisingtamang and I'm a VCU third year nurse anesthesia student. Today I'll be showing you how to place an epidural as part of my DNAP project. So please watch until the end and let me know if you have any questions. Thank you. Before we begin the procedure, I wanted to give you a visual of a list of a task-specific checklist. It might seem like a lot of steps at first, but they follow a natural and logical flow. With a few practice runs, you'll find that the process becomes more second nature and easy to perform without needing to memorize each step. When the patient indicates they are ready for an epidural placement, first ensure that informed consent has been obtained, confirm that a brief history and physical examination have been documented, and that recent lab results have been reviewed. Gather all necessary supplies, including the epidural kit, PPE, emergency airway equipment, and medications for potential complications. Additionally, verify that the patient has a functioning IV line with fluids infusing. When the patient indicates that they are ready for an epidural, have them sit up on the edge of the bed. Make sure that the patient is not sitting up on the crack of the bed. Make sure they're away from the crack of the bed so that their hips are midline and they are not leaning one way or the other. Whether the patient wants to be seated or be on their side, you need to know how to position them. An OB nurse is usually on the other side of the bed, facing the patient and helping the patient position. Depending on the facility, there may be a positioner. If not, have a chair for the patient to rest their legs on. Explain everything you do to the patient and provide clear instructions. If the patient doesn't speak English, utilize an interpreter and wait until the interpretation is completed before you do anything. Proceed with timeout. Then instruct the patient to put their chin to chest, relax their shoulder, hug the pillow in front of them, arch their back while leaning forward. Once the patient is properly positioned, begin palpating for anatomical landmarks. Start by locating the top of the iliac crests bilaterally and bringing your thumbs together to form a transverse line, commonly referred to as Touvier's line, which approximates the level of the L4 vertebral body. Palpate the area thoroughly to identify the spinous processes and determine the midline. Once you have confirmed your landmarks, mark the site of intended needle insertion. You can use a marker, the tip of the needle cap, or your thumbnail to mark the site. Here, I used my thumbnail to mark the site. Now that the insertion site has been marked, I'm going to open the epidural kit. Keep in mind that epidural kit contents and layout may vary slightly between institutions, so it is important to familiarize yourself with specific setup at your facility. Before you open the kit, make a note of the lot number and make sure it has not expired. This kit has expired but is not going to be used on a real patient and is for demonstration purposes only. A standard epidural kit typically includes sterile drapes, syringes, filter needles, a two-way needle, an epidural catheter, and often some basic medications. If the included medications are not in the desired concentrations, be sure to confirm the availability of appropriate local anesthetics and adjuvants prior to starting the procedure. Open the kit using aseptic technique to prevent contamination, then don appropriately sized sterile gloves. A link to YouTube video demonstrates proper sterile gloving. Please review it if needed. In the next video, note the color change indicating I'm now wearing sterile gloves. Begin organizing the contents in the order of use, arranging items from first to last, and remove any components you do not plan to use in order to maintain a clean and efficient workspace. These are the contents of the epidural kit. The medications are supplied in glass ampules. This is a two-way needle which has striations for depth markings. There are 9 striations up to the butterfly hub indicating 9 cm, with the full needle length extending to about 11 to 12 centimeters. This is an epidural catheter which also has depth markings. The blue tip marks the start of the catheter, followed by a single dot at 5 cm, additional single dots at each subsequent centimeter up to 10 cm, marked by double dots, a wide blue band at 12 cm, then 3 closely spaced dots at 15 cm, and 4 closely spaced dots at 20 cm. I'm going to show you putting the actual catheter through the two-way needle and show you the measurements here. I've initially placed it through the introducer little blue tip right there. I'm going to take that out and I'm going to show you from the tip of the needle to the hub. It's between 11 to 12 centimeters. This is for demonstration purposes only, so please never pull back on the catheter with the TUI needle still in. It causes shearing and can be detrimental to the patient. Break the glass ampules one at a time and draw the medications in appropriate syringe with the straw needle. You have 1% lidocaine, which you will draw up in a 3 ml syringe for skin numbing. After you draw up, make sure you label the syringe before putting it down to prevent any possible medication error. Next, draw normal saline into the glass loss of resistance syringe. Before doing so, ensure the glass plunger moves freely and falls under gravity when held upright. Use the straw needle to fill the syringe, then label it appropriately. The third medication to prepare is the test dose, which contains 1.5% lidocaine with 1 to 200,000 epinephrine. Using the straw needle, draw 5 ml into the 20 ml syringe and label it clearly. For reference, administering 3 ml of this solution delivers 45 milligrams of lidocaine and 15 micrograms of epinephrine. The securement device must be inserted to the catheter through this end, then push and snap the yellow tab to lock it in place. The epidural catheter label should be applied to the catheter once secured. Let the patient know you're cleaning their back. Hold the prep stick tipped downward to prevent dripping onto your arm, and clean in a circular motion starting from the center and moving outward. Allow the prep to dry completely before placing the sterile plastic drape on the patient's back, taking care not to contaminate it. At this point, instruct the patient not to move or touch their back. The drape is not supplied separately from the epidural kit. If it becomes contaminated, you will need to open a new kit. Take your time to position it correctly. Inform the patient that you're numbing the area and ask them to remain still. Inject the local anesthetic at the marked site to create a skin wheal, then advance it into the subcutaneous tissue, noting your needle trajectory and the feel of the intervertebral space. With the bevel up, insert the TUI needle along the same trajectory as the local needle, advancing through the skin, subcutaneous tissue, supraspinous and intraspinous ligaments. Make sure you have control of the needle at all times by simultaneously holding the TUI as well as by grounding yourself to the patient. When you reach the ligamentum flavum, you will feel a crunch. Stop at this point and make sure your TUI is safely wedged between the ligaments and seated properly. Remove your stylet and attach the glass syringe. If you added air in your syringe, give it a firm tap and see the air bounce. Advance a few millimeters at a time and tap as you go. When you reach the epidural space, you'll feel a give and your saline will easily enter the epidural space. This is the air technique. In the next video, I will show you saline technique. I have loss of resistance right here. You can do either technique, but for saline technique, get rid of the air and apply continuous pressure on the plunger with saline only. When the saline goes into the epidural space easily, it confirms loss of resistance. Let's do a close-up of where our loss of resistance is and be ready for some calculation. As you can see, there are 2 striated markings left on the TUI needle, so we know that we are 7 centimeters in. You should leave about 46 cm of the epidural catheter beyond the point of loss of resistance. Leaving less than 4 cm increases the risk of dislodgement, while more than 6 cm can lead to unilateral log or hot spots. You can pause and look at the marking at the skin here. Take the epidural catheter with the blue threading assist device and start threading the catheter. In this case, my loss of resistance was at 7 cm, so I'll advance the catheter to about 16 cm to leave 4 cm in the epidural space to ensure adequate depth. Also warn the patient about possible paresthesia during catheter threading. Carefully remove the TUI needle while simultaneously advancing the catheter to avoid accidental withdrawal or shearing. Once the needle is completely out, loop the catheter in your hand and secure its tip. Attach and lock the securement device in place. Then check that the catheter is positioned at 11 cm at the skin, adjusting by gently retracting if needed. Right there, the catheter is at 11 centimeters at the skin. Next step is the test dose. I will make a note of the patient's heart rate and blood pressure and withdraw on the syringe for negative aspiration confirmation. and inject 3 cc's. After giving the test dose, if nothing happens, the epidural is in correct place. If the patient's legs feel warm or heavy, the catheter is in the intrathecal space. If the heart rate increases by more than 20 beats per minute within 30 to 60 seconds due to epinephrine, the catheter is in the blood vessel. If the patient's vital signs remain unchanged, I'll go ahead and secure the epidural catheter with a transferrin dressing so you can see the insertion site for future assessment. Remove the drape and finish the dressing. The final dressing should be secured with tape at all four corners of the transparent dressing, plus one long strip of tape running along the length of the epidural catheter over the patient's shoulder on the side of the nearest IV pole. Now that we have covered how to place an epidural, let's review how to remove it. After delivery, when the epidural is no longer needed, explain the procedure to the patient and have them sit up with their back slightly curved towards you. Gently remove the dressing, then apply steady, gentle traction to withdraw the catheter. Never pull forcefully, as this can cause the catheter to break. Once removed, visually confirm that the blue marked tip is intact. Finally, have the patient lie back comfortably and document your findings.